reached almost in the last few sessions of our series of webinars, and this is going to be on a subject which is really hitting up the entire device market in the last 2-3 years, that is remote monitoring. And we'll hear what is new in remote monitoring and how is the future look like. So we have got Dr. P.C.Mondal, Dr. Anil Mishra to moderate the session, and two speakers, Dr. Chaudhuri and Chander Mohan Thakur. So let me turn it over to Dr. P.C. To carry on the session and to take us through the session. Akashda, over to you.
Yes. Thank you, Dilip. And it's a good arrangement. I think the webinars are going very fine. So today's topic will be remote monitoring on electronic devices, and the clinical need. That part will be discussed by Dr. Soumik Chaudhuri. He is a consultant interventional cardiologist in PRLS Hospital, Kolkata. And regarding Dr. Soumik, I have gone through his biodata. He's MBBS from Jipmar, Pondicherry, and done his MD from Rotak, and also DM cardiology from IPGMR, Kolkata. And he has got number of publications in this age. He is much junior to us, and he has written several book chapters and also participated in so many trials. In this age, he has participated in a few trials also. I think he will be a right person to go ahead with this topic. And without much delay, we'll start his topic, that is remote monitoring in electronic devices, the clinical need. Dr. Soumik.
Thank you so much, sir. Thank you so much. That's really sweet of you, sir. Thank you so much. I'm a child compared to you.
My voice is clearly audible to everyone?
Absolutely, sir. Very clearly audible, sir.
Okay.
Yes, sir. It's audible, sir.
Okay. I think maybe my net is a bit unstable
No,
now.
sir, your sound is very clear, sir. Sir, thank you so much again. I mean, sir, in front of you and Dilip Kumar, sir, I am a child. So please, I'm not even in the same room. So,
maybe not in knowledge.
No, sir, in every which way. Every which way, sir.
Dilip is junior to me also. Dilip?
Yes,
you
sir.
are
He's a bright chap, yeah. And Soumik is is a shining star, and he will do good. So
Thank
Soumik,
you so much,
you can start sharing your screen. And
yes, sir. I'm starting, sir. So as you said, sir, it's quite a hot topic right now.
Yeah.
The concept of remote monitoring of cardiac devices, and as more and more time is coming, I think this is something which is going to become much bigger. So without further ado, sir, I will start off the concept. So what we are going to be discussing today is the concept of remote monitoring of the cardiac implantable devices. Now, devices have been there, the implantable cardiac devices have been there for a long time, and over time they have gotten excellently refined. They are beautiful devices with a wonderful technological background. But one of the things that was always a slightly, I would say, a lacuna in the system was the fact that the only time we got to see what was happening or got to know what was happening was when the patient was coming to us in the clinic, when a programming was being done. Between programming, we really had no idea what was happening with the patient, whether the patient's data, whether the patient's rhythm, rate, or any other parameter was abnormal. This is where the remote monitoring basically comes in. So as it is the COVID pandemic all around us, so advancing technology, and I would say probably the pandemic where people are afraid to leave their houses more right now, people are probably feeling safer in their house, is actually creating even a bigger opportunity for the remote monitoring. On one side, we have an increasing life expectancy, and patients with heart failure or patients with devices are now living much longer than probably even a couple of generations back. On the other side, there is the macro trends and the industry trends. Taken with COVID-19 together, this is basically helping us in the remote monitoring. Now, the matter is yearly, annually, if you see all over the world, the number of devices that are being implanted are rapidly increasing. But the clinic capacity is really not going to increase so rapidly. The clinics will not go up as much as the devices will be there. So in that context, what we need to understand is that the implantable cardiac defibrillator, the ICDs and CRTs, the more and more that these are being put, the more and more they are being implanted. The clinic capacity to handle them, to have a regular follow-up for them is not going to be the same. So what are the demands that is basically there in the device? One side is the patient demand. And as I think most of my colleagues and my senior sirs would agree, most of the patients now want a greater responsibility in managing their health. They're not passive anymore. They don't want to be just a passive patient who's guided or directed by the doctor or the physician. They want a greater responsibility. They want a greater role. The family wants a greater involvement in their therapy. And what most people, I think, would agree on, convenience and consistent. The patient basically wants something which is convenient for him and which gives him consistent care. On the other hand, clinics are facing escalating volumes and a pressure for time. And these devices are not just simple random, any Tom, Dick and Harry can come and go and program them or have a look at the data. It requires proper staff recruitment, retention. So then what occurs is if a staff leaves or a staff goes out, there's a disruption to the continuity of care. Taking these factors together, the concept of automatic remote monitoring, a monitoring which is not human based. It is a continuous remote monitoring of the patient's device, which is coming throughout the time to the physician as well as a recording system. It can give us a tremendous amount of improvement, which we will be talking about through evidence after this. This is not just a random thought, it's through evidence based that we're talking about. So what happens basically? First, you have your device. That's your pulse generator or the whatever is the device that we have. So that is here. After that, we have the basically the monitoring, whether it's the home monitor system or the Merlin system. You'll see each company has a different proprietary system. From there, it basically through the GPS or the Wi-Fi or the broadband, it is then goes to the server farm where the data is set up, where the data is stored. From there, the data is processed, and finally, you have the interpretation of the data. That interpretation also can reach the physician as well as there is a dedicated team for interpretation and handling that data. Now, as I said, this is not just, it's not about one company that we're talking about or just one proprietary system. If you look at the big five, the Biotronic, Boston, Medtronic, Sorin, and obviously Cied'S, all have their own specifically patented system. For Biotronic, if it is a home monitoring, Cied'S has the Merlin.net. Sorin has a Smart View, Boston has Latitude, Medtronic has a CareLink. Now the data, I'm not going to go into the exact details of this. The only part I would like you to see in this are the special features predominantly and the concept of FDA clearance. All of them are FDA cleared. All of them are FDA approved. They all have the CE mark. So they are also technologically what is required, they have it. And the special features, they can alert fully configurable alerts. A core view fluid status, this is very important. The core view fluid status will come to later. An automatic pacing threshold checking, integrated heart failure website correlation, and there's a very good trial on this after this we'll talk about. We can look at the patient. In fact, there are studies which have happened, pilot studies, and are going on right now, which actually say, can we even predict heart failure occurring again in these patients? We might be able to do that. And the default alert system is daily. You can make it maybe for a patient who is relatively or remarkably asymptomatic. We can even make it maybe weekly or maybe once every 3 or 4 days. This is all configurable. This is not hard and fast the system that is set up. Now I'll come to the data that we have, because this is not a gimmick. This is not just a associated feature. It might be nice to have, but probably does not do anything for the patient. It's absolutely not that. It actually has mortality, morbidity benefits, and this is borne out through the data. So this came out in Circulation in 2015. Basically, they wanted to see the Kaplan-Meier survival curve, where remote patient monitoring, the RPM, was used in patients at a 90-day landmark interval. So what they found was the patients in whom RPM was being used, remote patient monitoring, actually had a lower risk of adverse outcomes among patients with ICD. So the patients who had an initial ICD implant, if they had an RPM which was on, they would actually have a significantly lower risk of adverse outcomes. This is a very good data, and this is the one which I was actually probably most intrigued with. This is 2015 in Jack. Just look at the number of patients who were followed up. 269,471. It's a huge number of big data that we have. They used this big data, consecutive US patients, 2008 to 2011, those which had a remote monitoring facility, because by that time, most of the devices that were being implanted in the US had a wireless remote monitoring facility. So they found what was the level association between the level of adherence to the automatic wireless remote monitoring and the survival in patients with pacemaker and DFib. So we were finding, was there a mortality benefit if the remote monitoring was being used? So what they did was they made 3 groups, and we'll see those groups in the next slide. They took up something called the percentage of time in remote monitoring, the time that the patient required to be in remote monitoring, the percentage that the patient was there in remote monitoring, that is percentage TRM. They made 3 groups. One group was a patient who was more than 75% time in TRM, so they called it a high TRM group. Then second was a patient who had less than 75% in TRM, that is in remote monitoring. They called it a low TRM group. And finally, the third one was patients who had remote monitoring switched off. So no remote monitoring, 0%. 3 groups they looked at as they went from the years from implants. The high TRM group as compared to the no TRM group almost had a twice mortality benefit. The hazard ratio was 2.1. That's huge. They had a twice, almost 2 times better mortality improvement as compared to the patients who had no remote monitoring switched on at all. Even if you compare patients who had a high and a low remote monitoring, that's a high percentage TRM versus a low percentage TRM, even then the hazard ratio is 1.32. So there was a 32% improvement in survival, even with the amount of time that the patient was in remote monitoring. So it is not just an all or none. It's not just switching it on or switching it off. The amount of time that the patient is kept in remote monitoring actually directly proportional to the benefit, the mortality benefit in these patients, the survival in these patients. So coming to the next part, this is from specifically Merlin data that we have. Now the Merlin data, what they did was, this was across the spectrum. Pacemakers, ICDs, CRTPs, and CRT combos. All 4 data they looked at. Again, we subclassified into a high TRM versus low TRM, high TRM versus no TRM, as well as a low TRM versus a no TRM. Across the board, all devices, the patients were percentage in TRM versus the percentage without TRM showed significant improvement. This was all data, whether it was a pacemaker, CRTP, CRTD, or an ICD, all of them showed a significant benefit when the patient was in remote monitoring. In all of these cases, the high TRM was slightly or a little more than slightly better than the low TRM, except for probably the CRTs. The CRTs, the high TRM versus low TRM was better, but not so highly as the other one. But whether these associations were in the pacemaker group, ICD, CRT, if the patient was in remote monitoring, there was a definite remote monitoring survival benefit. Now, this is a study, this was actually Piccini et al. And 2016, they wanted to see the remote monitoring with, and they wanted to associate it with the all-cause hospitalization. So they wanted to see how much was the healthcare utilization occurring among patients who were on remote monitoring. Again, pacemaker, ICD, CRTP, CRTD, the 4 main groups that we have of devices. All 4 groups, patients with remote monitoring had a significantly lower admission rate. Whether those rates, whether it's a pacemaker alone or a CRTP, in fact, CRTD has the best results. A mean was almost the 11, and without the RM, it was 11.2 days. With the RM, it was 6.7 days. So the all-cause hospitalization, healthcare utilization was much higher in patients who were on remote monitoring, who were not on remote monitoring, as compared to the patients who were utilizing remote monitoring. Now, this is something which I found very interesting. There are a number, I think most of my sirs would agree here, that a number of patients who usually a pacemaker or a device follow-up, after the initial few months is about a 6 month or a yearly for us. Then 6 months the patient comes to us, or a yearly maybe we are doing a programming for that patient, and we found that the patient has had some maybe 20 episodes of atrial fibrillation. And none of us knew they were asymptomatic atrial fibrillation. But that does not decrease his risk of the thromboembolic event. Now, what happened was probably the first episode happened 3 or 4 or maybe 6 months back. and we did not know, nobody knew. And this patient remained at a high thromboembolic risk. But what about if this patient had a remote monitoring on? If this remote monitoring was on, this would immediately get picked up that he's having new onset atrial fibrillation. And the management could be immediately attuned as well as individualized for this particular patient based on his new onset atrial fibrillation. So taking that, if you see the patients who were on remote monitoring, years or days after implant, they actually found that new onset AF was picked up much earlier in patients who had remote monitoring as compared to patients who did not. So the reduced time to diagnosis and treatment with implantable cardiac monitors. This is a study where they found that they put an ILR in 109 patients and either a conventional on-site follow-up or they did a remote monitoring, a care-link follow-up. They found that the time to diagnosis was 187 days lesser, where the time to diagnosis was 184 days lesser, and the time to treatment was 187 days lesser with a patient who had remote monitoring. I mean, that's an astounding number. These patients, and this is something which I have always felt when we have implanted device. I thought it's very good that we've implanted a device. But what about if this patient has something, he has an event or he has something which needs management, and I will only get to know about it after 5 months when he comes for a normal clinic on-site follow-up. We need to have something which has a continuous monitoring, but while the patient is not having to get inconvenienced by that. And this is where remote monitoring comes in. So this, based on that, there is a pilot study on the react.com, this study was called. And it's an excellent pilot study because it actually takes the concept of AF anticoagulation and turns it on its head. Now, we agree that AF patients require anticoagulation. It significantly decreases the thromboembolic event. But the problem remains that the major hindrance is also the oral anticoagulant causing the bleeding. So if we could, because most of these kinds of patients might not require a OAC. But because there is no way to know that, so what we have to do is to continuously keep them on oral anticoagulation. So if there was a triggering mechanism to understand that, maybe that might help. So here what the study design was, they had a scheduled daily transmission as well as an alert triggered or a patient triggered transmission. Initially, if there was a 60-day AF-free period, it would alert the patient to stop actually alert the team that was managing it, and they would give a call to the patient and ask them to stop anticoagulation and only start aspirin. In the next 30 days, if there's any point in the next day, any point of time patient has an AF episode which lasts more than an hour, then for the next 30 days, the anticoagulation would be consecutively continued. 33 days freedom from AF duration. Again, it goes back to the cycle where stop anticoagulation and start aspirin. So what it basically did was, in a conventional historic control, the patient would be on an oral anticoagulant 100% of the time, because that's what we would give to the patient. The target of this pilot study was to see, can we bring it down to 70% without increasing any risk of the thromboembolic event? And they actually found that they brought down oral anticoagulation to just 6%. The total patient days was 1,472 out of a possible of 24,320 days. Only 6% of these times these patients were on oral anticoagulants, and they had no increased incidence of either thromboembolic event or stroke. So without increasing the risk of the embolic event, the bleeding risk was drastically reduced. That's what this pilot, in fact, there is a larger study that is happening about this. So this is what the ThinGoo devices is called the Merlin at home, with 3 million existing device patients. Device patients are rapidly increasing. We have about 400,000 devices implanted annually. We need to monitor them effectively and efficiently to decrease the follow-up burden and also improve the patient's compliance. So as compared to a traditional office-based care, remote monitoring obviously will improve compliance. You have decreased number of patients lost to follow-up, and more importantly, and this is what I believe is the main clincher, clinically actionable events, the CIEDS, will be rapidly diagnosed, 79% faster than a traditionally followed patient. Pacemaker patients have a rapid detection of the CIEDS. So it can actually, there are times where a patient will have a symptom. Patient is having giddiness. We are worried, what's happening with him? Is there something wrong? Is his device malfunctioning? Immediately say, you come in back. You come to the emergency, we'll have a look at your device. But still his remote monitoring is on. You do the remote monitoring. You find that there are no events, there are no arrhythmias occurring at that point. There is no clinically actionable event occurring. So you know it is not an emergency in that particular context. So maybe this can help reduce the emergency department admission, the urgent in-office visit, and also the clinician gets more time. He gets more time and a time more suitable to him to actually work on these events or to work on these alerts. So what are the benefits? We'll just go quickly through it once. Closer follow-up. There is a huge reduction in time from the events to decision. A time from diagnosis to treatment with ILRs and ICMs. Faster diagnosis. And a greater adherence to follow-up. Because there's an early detection, increased adherence, increased survival, and at the same time, this leads to decreased healthcare utilization. The concept of overflowing healthcare utilization is a big reality right now. More than half of, I just say more than 70% of our resources have now gone behind one disease. But that does not mean everything else is going down. They also need to be given their importance. So in that context, if we have concepts or systems to decrease the healthcare utilization while not decreasing safety in them, we can definitely improve their mortality, morbidity, as well as the patient's adherence to the therapy. Clinical efficiency improves, patient satisfaction improves, decrease healthcare utilization, increase clinic efficiency. As I said, remote monitoring is not an add-on, it is not a gimmick. In fact, it's a class 1 recommendation and has been for the last 5 years. Remote monitoring is now recognized as a standard of care. The 2015, the Heart Rhythm Society consensus statement, a strategy of remote CIED, that's cardiac implantable devices, monitoring and interrogation, combined with at least one annual inpatient visit, is recommended over a calendar-based schedule. That's a class 1A indication. All patients with CIEDs should be offered RM, a remote monitoring, class 1A. Remote monitoring should be performed for surveillance of the lead function and battery conservation, early detection and quantification atrial fibrillation, and to reduce inappropriate ICD shocks. All of this are class 1. Most of these are class 1A indications. So this is not something that we are going to be adding to the standard of care. This is the standard of care. If the patient has a right to be told about this, that this is the standard of care that is there now. But regardless of the fact that this is the standard of care, most of the patients, whether it is St. Jude's, whether it is Boston, less than half of patients actually are utilizing the remote monitors. And even in the 47% that is utilizing it, most of them are in the Western world. In the Indian scenario, it is drastically underutilized. So the clinical benefits, just to rehash, faster time to clinical action, lesser time at the doctor, lesser time at the hospital, and more time for living. It will actually improve the survival rate. Is it just something we are saying just like that, or is there some data behind it, which could be coming in more? So patients who are more adherent, this is from Medtronic's remote monitoring data, actually have a 53% greater survival than patients with low adherence to remote monitoring. So patients with remote monitoring actually do better in terms of survival. Economic benefits, reduced healthcare utilization. More important, even for the patient, there's a reduction in the healthcare utilization. That saves money. A 35% potential reduction in ER visits saves the patient money. It saves the patient time. Up to 1 in 2 patients of CRPD would probably require a baseline hospitalization recurrently for things which might be potentially reducible. But these patients, without remote monitoring, it's difficult to understand that. So just an idea, how does any of them, let's take Merlin as an example, patient divide the device. One side you have your classic clinic follow-up, what we use, the inpatient follow-up. But you have your Merlin at home, the radio transmitter. goes to the PC network. On one side, it goes to the electronic health record where it is documented, and at the same time, the data comes into the physician, the implanter. So it's not that the data is being lost. There is a data repository. Along with that, the clinician is also getting the actionable events. The data that has come in before, as we are talking about a lot of this, the Compass trial, where this is UMPS Compass, Evolvo, Prefer, Altitude, Bradicare, all of them had a lot of patients of heart failure who had associated remote monitoring was on for these patients. Even the Merlin data of St. Jude that came in 2006, all-cause survivors, and that actually had the biggest number of patients, 102,000 patients. So what's new? Is there more data coming in? Are there more trials going on right now? There are a lot of trials that are on, a lot of trials that have completed, and the data and the final results are to come in. I'll just quickly touch over them. There's the Virtue, which is the virtual clinic pacemaker follow-up. This is to see if you randomize 120 patients of DVDR pacing, keep half of them on a clinical follow-up every 12 months, and the other one is home monitoring data analysis with no scheduled follow-up, only event-based follow-up. They want to see whether it significantly decreases the clinic load or not. If you want to look at the quality of life, same thing, 150 patients with ICD implantation. One patient has home monitoring alone for 9 months after implantation. The other has home monitoring immediately after implantation. The other one is 9 months after implantation, one is immediately after implantation. And they want to see the psychosomatic effect of this, whether it improves the hospital anxiety and depression scores, whether it improves the quality of life for these patients. If you want to look at cost effectiveness, and this probably is one of the biggest hindrances, at least in India with remote monitoring, this is the Euro-Eco trial that's on. That's basically about 300 odd patients with ICD indication. One group of patients with home monitoring activated, one with home monitoring off, the control. They want to see whether the documentation, the time spent, the follow-up activity, whether is the follow-up activity and the documentation of the remote monitoring more than the inpatient visits, or whether they actually attenuate each other. So this is what Euro-Eco is looking at. I was looking at the data of Euro-Eco. They have found that there is really more, some of the data is on the net. They have found that mostly there is no significant difference. So the remote monitoring actually is not more expensive than an inpatient monitoring, which is a common perspective that people have, that this is frightfully expensive, hence probably we might not go for it. Coming to the Spirit ICD, 500 plus patients, ICD with home monitoring, with a previous MI more than 40 days back, EF less than 30%. On one side, a standard follow-up. On the other side, the intensified follow-up with home monitoring, diagnostics and treatment. And they're going to follow up for 12 months and see whether the intensified treatment with home monitoring actually improves the all-cause mortality or even the recurrent heart failure hospitalization. Impact is for seeing, as I talked about, the home monitoring guided anticoagulation, which was basically the react.com. 2,700 plus patients, ICD or CRTD, a Cied'S score which is more than 1. Half of it a conventional physician-directed warfarin. The other half is an atrial tachycardia episodes on home monitoring, AF episodes, and then individualized in the initiation, along with a regular AF monitoring and taking off of the anticoagulation. There's a 30-day gap at least of no AF. What are they going to look for? The stroke, systemic embolism, and the major bleeding risk. Now, the home care too is very interesting. This basically, and this is called the core view. This is there in the Merlin net. It's a monitoring of the fluid status in the heart failure patient by an intrathoracic impedance measurement. So basically, they want to see whether the intrathoracic impedance-based detection algorithm, can it predict the clinically relevant heart failure event? This is what it's going beyond just the data of the device itself. Can it look around and try to predict the heart failure? In fact, I think I missed the slide. No, it's I think later. Yeah. So in time, this is for influence of home monitoring on the clinical status of heart failure patients. One group has standard care, the other group has standard care plus home monitoring. Again, whether there's a mortality benefit, a morbidity benefit, reduction in heart failure hospitalization, improvement in the NYHA status, all this is going to be followed up over a period of 12 months. Now the effect trial. The effect trial is basically the clinical effect of heart failure management via home monitoring with a focus on AF. On one side, you have home monitoring deactivated. And one thing I just want to make a point. A lot of people might say that if a home monitoring is available just for the trial purpose, deactivating it, is that safe? There's something called safety net. When we say home monitoring is deactivated, the safety net protocols, like a patient is not pacing, if the patient's thresholds have gone rapidly up, if there's a sudden change in the impedance, if there's a VTVF event, those, regardless of whether home monitoring is deactivated, will be actioned upon. They will be generated, the alerts will be generated on that. So when we say home monitoring is deactivated, we mean the routine activity that we're talking about, not the critical events. The critical life-threatening events will not be deactivated. The safety net is always on in these patients. So home monitoring activated versus deactivated, focus on AF and CV mortality. And the Castle AF, actually the reason I bought it, the Castle AF does not look like a classic home monitoring stand. The Castle AF, actually why I brought in, now it was catheter ablation was the standard conventional therapy for heart failure patients with AF. All of these patients, all 420 patients, actually had a home monitoring which was activated. These patients with a home monitoring activated actually could be tracked. So this is the home monitoring was tremendously useful in the Castle AF trial. So these patients could be tracked and the events could be standardized. So as I said, some of the recently concluded Virtue, Quantum, EuroEcho, Home Care 2, Castle AF, Spirit IC, the FX. So the evidence has come in and more coming in. So it's not something which is just a thought in the air. This is evidence-based medicine. So just I would like to sum it up with a few take-home messages. Remote monitoring and follow-up is likely to become the standard of care for patients with pacemakers and ICDs, as they have the potential to improve patient safety and satisfaction, to support efficient use of resources, and to reduce costs. The existing data shows that the current technology for remote monitoring is reliable and is readily acceptable to the patient and the physician, and more large randomized trials are underway right now, which will probably and hopefully prove that remote monitoring improves patient outcomes. I think the main concern with remote monitoring that remains right now is the specific issue of reimbursement and insurance coverage. If this is properly dealt with and the cost effectiveness or the economics of a remote monitoring are handled well, it is definitely a viable solution which has mortality benefit, morbidity benefit, and also helps to improve our use of clinical resources. With that, I think I will conclude my session here. Thank you.
Thank you, Soumik.
Thank you, sir.
I think that's a nice presentation. You have elicited all the benefits, particularly focusing on heart failure deterioration and rehospitalization, because it increases mortality with each readmission. Heart failure patients' mortality goes up.
Absolutely.
And that's I think a real advantage, and detection of atrial fibrillation and timely initiation of anticoagulation, particularly in the NOAC era. It's a really a great advantage. And all the studies are in favor of remote monitoring. And it has been shown that is cost-wise, it is also effective.
Yes,
Plus,
sir.
it is safe also. And from in present COVID pandemic situation where we avoid contact with the patient, that means contactless monitoring is also warranted. But only one thing that is getting left is very much underused in our country.
Yes, sir.
Opinion of you or our esteemed panelist regarding this, why it is so much underused in our country? That's a big question till now. It is giving benefit in all aspects, clinically beneficial in many areas. It is life expectancy got increased, cost-wise also cost saving, but it is still underused. What can it be the cause? I think from industry side also they can highlight what are the obstacles they are facing now to introduce this kind of remote monitoring devices. And what is the experience of Dilip? Why the patients are not accepting, or the physicians are not giving a positive input to the patient or patient relative regarding these monitoring devices? Any comment, Dilip?
Yes, sir. in the meantime, let me welcome Dr. Anil Mishra. I think sir has joined, and we would like to have his inputs also.
Sorry, I was a little late in coming from the hospital.
Good evening, sir.
Yes, but very wonderful talk. Soumik, you really covered it very well. You got
Good
it
evening, sir. Thank you,
all
sir.
the aspects covered about the devices, about the supporting evidences, and what are benefits to gain. Now, the question is why it has not been accepted well in our country. I think the principal cause initially was the costs. People had to spend about $1 lakh more to get the devices which could do a remote monitoring. And it was a little cumbersome for them because they're not technical people, patients. So they're connecting to the device, keeping it in their home, even in bedside. This became simpler in due course of time. However, even physicians were finding it a little difficult because they are not tech savvy. And a lot of cardiologists who are not tech savvy or find it difficult to follow it on the computer and so on and so forth. I think these were the two principal reasons. Thirdly, at the start, the evidences for benefit were very limited. Now we have got a widespread data covering the various aspects like atrial fibrillation, covering the heart failure, covering the mortality, and saving the costs as well as visits, so on and so forth. So the huge amount of data now available, really pushing it up to class 1 indication. So I think one thing important still is they still have to buy a device to be able to transmit it. But I think there are new development coming in. Everybody now owns a smartphone. So I think in due course of time, we'll probably hear more about it, that if the devices could have built in, like they have initially, they did not have capability to transmit directly to the programmer. You had to place the programmer head over it. Now, if they had later on developed capability of directly communicating with the programmer wirelessly, similarly, if they could wirelessly communicate with the software in your cell phone, and that could automatically transmit because it has a SIM, all cell phones have a SIM. They could transmit to your center. This would become much easier, and therefore patient resistance won't be there. It will be cheaper because you don't require any extra equipment. It will be built into the pacemaker itself. And of course, physicians will have to get used to this new system of follow-up. And once they learn, it saves 50% of the time, and they can treat the patients early, detect problems early. I'm sure the acceptance is going to come around. It'll take a lot of educations to go around that.
Thank you, Dr. Mishra. I think with the increasing use of net and smartphone by our rural people, this use will go on increasing with time. I think because this most of the Indians not in urban areas, most of them are in rural areas. Net use in the rural areas was much less. In last few years, rather last few months also, it is gearing up too much. I think with that, I think this will also be accepted by the people also. And from physician side, they should accept that this kind of clinical benefit, we should highlight that area, that detection of heart failure, that a patient is accumulating fluid, he may get admitted, or his therapy to be modified, and that area to be highlighted. I think that company people also has got role to penetrate in that area. They should give some booklets and other thing to all the patients who are going for any device implantation, whether it is pacemaker or ICD or CRT. They should educate the relative. They should spend some time and they should give some booklet so that they can spread that education also to other fellow patients also. So that with time we can increase our use, because we are being criticized that Asian people are using this kind of monitoring devices much less like this. But I think that can be overcome with this kind of activities.
Yes. We have some discussion on number one is a flip side of if there is any security issue or security concern regarding monitoring.
Some of the physician has asked me, Dr. Mondal, you have suggested for my patient to have a remote monitoring devices along with CRT. Can it be hacked and can it be made off by someone else? I think that is one question you are going to ask, whether something can be done by a third person. That's one issue. And second issue, during handling in the home, some bad thing can be created by suppose by son or by daughter, by wife. They are trying to manipulate the device and they have created something. Is that a possibility? That's a possibility.
Dr. Mishra, I think you spoke of this cyber,
cyber hacking one.
Right. Basically, they are now all security coded. Therefore, hacking is not easy. Even if they are able to hack, Fortunately, at the moment, you cannot program the devices through this. So you cannot really change the basic programming of the device. So even if you hack, you may get some data which you can read, but there are a lot of security issues, and they have come around. The companies have really built in double security systems into the device. I think Chander Mohan may know a little more about how security is built up and how secure it is, the encryption technology. And one good thing is, even if they hack, they cannot ever harm the patients, because we still do not have capabilities to really change the programming of the device based upon that. In future, who knows, you may get an OTP before you really can do something to the device, and programming may come through the device as well. So that is a food for thought.
I have a question to Soumik now. Soumik, do we have any consensus regarding duration of atrial fibrillation which you detect through remote monitoring and its consequence on thromboembolism and clinical significance?
Not really, sir. Basically, what the for the trial protocol, what they took was there had to be an initially 60-day period of no AF first for it to go into an event.
Sorry to interrupt you. Hear me out. The idea is, this is not only one trial. Many trials were there earlier also, and there was a cutoff kind of 6 minutes duration of atrial fibrillation on remote monitoring. Was a deciding factor. Those patients were to be given anticoagulation, and before that, like in many Holter monitoring reports, you get to see 4, 5, 6, 10, 11, 12 beats of AFib, irregular atrial rhythm, and then nothing to be done in these patients. You can add these patients ranolazine or beta blocker. You can comfort the patients, but there's a 6 minute was a kind of consensus regarding that. So has it changed with this 1 hour, 30 minutes? Because 30 days, 1 hour, and is there any consensus regarding the duration?
No, sir, not. As far as I know, so there's no frank consensus for this particular purpose. They had used the 1 hour for 30 days purposes. But I don't believe that there's any frank consensus on that. Maybe sir, Mondal sir or Mishra sir could tell us if there's anything further on this, because I do not believe there is any frank consensus on this.
No, I don't think there is any guidelines suggesting that at this point of time. This is one just proposed thing. There may be some more evidences coming from other studies about the various durations, how long the atrial fibrillation would be considered successful, a treatable one, and how frequent would be considered treatable one. So this is still a gray area. There is some data coming out randomly, like from your study, what you quoted, and the other studies as well.
Yes.
But still, there are a lot of questions to be answered. Everybody is not sure what is the exact amount of atrial fibrillation you would want to treat, and what exact amount of atrial fibrillation is safe not to treat with anticoagulation.
Regarding A burden and initiation of anticoagulation, there are some guidelines, but on remote monitoring or Holter, there may be few bits of irregularity that will not qualify for initiation of anticoagulation. And that strips that we are going to analyze that area, that should have a stampable atrial fibrillation, not a mere irregularity that is detected by your monitoring system that there is an AF like that. You have to analyze clinically, and you have to assess the score of risk of thromboembolism. Then we can initiate anticoagulation. That means it needs a clinical correlation, clinical diagnosis, and also clinical risk of thromboembolism and assessment of bleeding risk also. All these 4 to be satisfied before initiation of anticoagulation. Because on remote monitoring, initiation of anticoagulation is not like clinical documentation of atrial fibrillation. That's why though there was no actual guideline, but in your this radiofrequency ablation trial, that's a sub-study you have shown, Dr. Soumik, you have shown. That shows that here few bits of irregularities is not a recurrence of atrial fibrillation. They have detected that also, that how much patients are recurring after a radiofrequency ablation. Not that a few bits of irregularities that is happening, suppose 6, 8 episodes in a day.
Yes, sir. Absolutely.
Not qualifying that it is a recurrent.
Yes, sir.
Continuous irregular beat, that strip can be analyzed, and that can be stamped as a clinical atrial fibrillation. Then and then it can be a
recurrence of the
atrial fibrillation. Like that, during your initiation of anticoagulation, either VK or NOAC, it should be a clinical diagnosis of atrial fibrillation. I think our next speaker's talk is more on that area, how we can go ahead to correlate this kind of arrhythmia with clinical scenario, and what are the improvements we can make in future regarding security and other threats. I think we can proceed to the next lecture also, if Dilip permits.
Yes, sir. You are the moderator, Dr. Mr. And you can.
Yes, I think we are fine. As I said, one point before we go on to the next topic, it is, yes, it's very important to diagnose atrial fibrillation rightly, but what he presented in the study, that if you have 60 days free of atrial fibrillation, you discontinue the anticoagulant. And what is the evidence to support that is very important question to be answered.
Absolutely, sir. Because the evidence for that is still not winning. That was a pilot study. So it needs, definitely needs much more evidence than that.
Thankfully, there is episode of thromboembolism in that study as well.
Yeah. Okay. I think then we move on to Chander. Let's go on. Let's hear more interesting things. We cannot hear you yet. Chander?
Yeah.
Yeah.
Hi, good evening, everyone, and thank you very much for inviting me for this talk. I hope I'm audible. If I can have one confirmation.
Yes, please. We can hear you well, and we can see
Thank
your
you.
slides as
Thank
well.
you, Dr. Mishra. So when I started this series, I think I was one who started, and we have, I think, gone long back in this series of device update. Today's topic is slightly difficult to handle, but I have a good company of expert with me, and Dr. Soumik has made my life slightly easy, where the convincing part or the clinical convincing part is done. So what I will not be touching is the clinical part of the remote monitoring. I will be more focused on the technology part. Even in technology, I will not want you to bore with the existing technology which you are aware. I will try to give some trends, the way industry is thinking, the way the developments are going on, and most of my most of my content will be pre-market content. So you will be seeing these technology coming in the coming time, in a year's time, 2 years time, and so we will be trying to discuss on that, and I'm sure I will probably not have answer and the full details of all, but that's I will go with that disclosure here. And though all of you know me, I'm Chander Mohan. I work for Abbott, but my content in this presentation will not be specific to Abbott. It will be mixed. So Abbott has no control on the content here. Okay, so this is what we have. We hear, or we are preparing our children or the next generation for. We talk about Internet of Things. We talk about analytics. We talk about cloud computing, social media, e-health, big data, and so on. So what are these things doing for us? Basically, by mid of this century, we will have 1/3 of our population as the aging population. And that obviously translates to more of chronic disease, which means 2/3 of this population will be carrying some kind of chronic diseases. And unfortunately, the way current healthcare system is, the 5% of the population is eating up the 50% of spending, which nowadays I think it's completely different. But overall, it is 5% of people who are eating up almost the 50% of healthcare spending, because people are living long, people are having the chronic diseases, and cardiac disease will be part and parcel of these diseases. But on the other hand, if we look at specific this to India, the story will be slightly different, because our aging is early, our cardiovascular age is early. So we are going to have this scenario slightly different from India, or rather worse for India to have it. So we are going to have much younger people with cardiac disease and all. But what is changing in the digital health world? The digital health world, the patient are becoming demanding. They need solution. They need collaboration. They want to be part of your treatment plan. To forget those days when the patient used to come to you, they used to surrender and doctor, whatever you do is done. But today's patients are not going to do that. They are going to do Google around. They are going to do internet searches and all. And patients are younger, and so is the focus of healthcare. So healthcare is, we call it as, and in technology term, we call it as a left movement. So left movement means we are not treating only the severely ill patient. Our focus is towards the healthier patient or a population health. That's where the preventive healthcare and the cardiac preventive healthcare is looking at. What else we are looking at from the digital health or the healthcare professionals are looking at is, if there is a data, is that data helping me? Is it giving me some actionable, sensitive information which I can action? So that's the inherent part. Otherwise, I will not invest in this. It'll be a waste of information or a garbage of information for me if it is not giving me a sensitive data or a sensible data. So this is another picture where the scenario used to be different. It used to be diagnosis, and then you start getting into the condition or a disease monitoring, and then you look for a treatment and all. But as I said, the focus now is also towards the left side of it. We are looking at people who are at wellness, who are looking at seeking care. So that group has also become a focus area, and that's where most of the healthcare professionals want to go. That is why we are all on a social media. We want people to be healthy, remain connected, and when they remain connected, but when they need healthcare, they come to the right resource and the right path. So there are solutions which all the industry all across are bringing in. So they are becoming mobile. They are becoming point of care. So these are some of the solutions. You can see that COPD, which is a chronic disease, the solutions are becoming the solutions are becoming remote. You can have a patch kind of a remote monitoring where you are looking at the breathing pattern, SpO2 ranges on a current level or a real-time basis. The devices are becoming mobile, whether it is your ultrasound device, which is now mobile based. Your testing is becoming point of care, blood testing and all, chemotherapy, everything is moving towards out of the hospital, and in hospital should be reserved for those people who are really needing it. And earlier they used to be out of ambient, and they used to be only part of your advise and be healthy and all, but now they are also your healthcare consumer sitting at home. So they are your healthcare consumer even at home, and when they would need, they would definitely come to you. So it is part of the channel as well. So this is how the healthcare is moving, as the digital platforms are moving. You know, there is Apple Watch, which was a watch, which was a luxury watch and all. Now it is taking a shape of a medical device, right? So we have all heard about the Apple heart studies and all, and many other companies, Sanofi, Proteus, Sanofi, Variety, Novartis. They are coming up with solution or integration of solution with some technology companies like Adidas and all those things. They are getting into remote monitoring. They are monitoring patient, all the clinical trial patient. Now that's the trend. They are monitored from home, whether how much of activity they did. It could be a mobile app. It could be their shoes. It could be a pill reminder and all. So everything is enabling for your therapy compliance. And that is where we will have to change, because the technology is changing. Dr. Soumik has already shown this slide, partially this slide, which talks about our device. Patients are increasing. Our device, not only they are increasing in number, but your clinic capacity is still the same. but your device patient are escalating because, and not only escalating, they are far more younger patient now, which used to be 10 years back. 10 years back, when you implant a CRT or ICD, your mortality expectation was always below 5 years, 10 years and all. But now ICD patient, CRT patient, forget the pacemaker patient, they are living much longer. So your capacity will be challenged in the coming time. On the left side of the screen, this is what is the interesting part. The remote monitoring, which was pretty flat, as Dr. Soumik was also mentioning, and all of you have said there are challenges, but it was pretty flat. But if you look at specifically after, this is the pointer I'm focusing on, February 2020. So immediately there is an increase in the interest, surge in the demand on remote monitoring, which is many fold. So there is, which was flat, but it is certainly now searching for remote monitoring as an option. COVID is one of the trigger for that. I somehow love this slide, which Dr. Soumik has already shown. The remote monitoring will not increase survival if it is not consistently used and frequently used. So frequency is very important. More frequently you use, more is going to be the straight away survival benefit. And the survival benefit is all across the devices, ICD, CRT and pacemaker, which means this cannot be a fluke. And that was a big thing at that point of time. Nobody believed that it could be straight away translating into the survival benefit, only a remote monitoring. So this is what is the typical remote monitoring clinic or a device clinic, where we are looking at data, which is device-based data. Then we are looking at heart failure management data. Dr. Soumik already mentioned the core view and other specific feature of that. And then we are looking at something which are device-centered approach. We already spoke about the atrial fibrillation detection and those kind of things. Can we do shock deliveries remotely? Those kind of things. And then patient-centered approach. If we need something, can your clinic get back to the patient, bring him back, change the medication? Can we get into some kind of a medicine compliance monitoring? And where is the data going? Is it going to EHR? Can we have a centralized data? So all those things we are typically doing, or at least the Western world typically is doing in a remote monitoring clinic. So this slide straight away explains what happens currently or conventionally in India-like scenario. Patient travel to hospital, transportation, and then he's interrogated, and then there is a programmer and all. Then the story ends there. It is not a connected world. It is completely transactional. And this is what remote monitoring does. Patient travels, need not to travel. He sends his data through GPRS, landline and all, and which goes to a company specific server, and then you access this here. And again, as of now, this flow of information as of now is also one way, which was a challenge, and I will try to discuss that as well, because the flow is basically flowing from patient to healthcare provider, and healthcare provider, if he does not respond in 1 transaction, 2 transaction, 3 transaction, patient also forget the device, and he says this is useless device. Nobody is looking at my data. I'm not getting any benefit of this data. So that is why there was ways that clinic or the device clinic should get back to the patient, make it as a closed loop, bring the patient back into the treatment plan. So that often was missing, and it is all often a missing component in the Western world as well. And that is why, despite of having everybody having a remote monitoring in the Western world, you saw the penetration is 20%, 25%, and always less than 50%, even in a clinical trial. So that is how poor it was, the compliance to remote monitoring, even in a Western world. So any guesses for this device? We can have some younger people voting, I think. .
This is trans-telephonic transmission.
I expected that from Dr. Mishra, and rightly so. And that means that exactly mean the younger generation have not seen this kind of a device. So this is where actually the remote monitoring took a birth from. So this used to be called as trans-telephonic monitoring, which used to be basically like a telephone, and the device data or a ECG data or a Holter data will get transmitted over a landline phone like a Morse code, tick 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 tick, and that will get printed or printed or stored on the physician side. So this is where this whole thing started. This used to be used for Holter and all. That was extended for devices and all later. Thank you, Dr. Mishra, for that. But where are we? What are the challenges for this? As I said, the remote monitoring, basically, I will talk about the technology. Technology was so far a big hindrance in the remote monitoring. And then we have term like remote monitoring and a remote follow-up. We tend to grossly exchange these terms, but these are different terms basically. And that is also a problem in the older device. When patient had to transmit the data, it's called as remote follow-up or a remote monitoring. When there is no intervention required from the device at all, and both the feature remote monitoring and remote follow-up are built in, that is where we call it as a next generation remote monitoring and follow-up. And then cardiologists, up to some extent, they were also a challenge for or a barrier for remote monitoring, the knowledge and all. Some people said it is not necessary. And by the way, this data is from Western world and little bit dated data. And that's what I was mentioning. Even in a clinical trial, the compliance of using remote monitoring was around 50%, even in a controlled clinical trial where there are people sitting and reminding them and all. So it wasn't great. But let's look at what industry as of now has to offer. Is Medtronic calls it as a CareLink, which was a box like this. Biotronic cardiac messenger. Latitude is from Boston, and this is from St. Jude, and this is from Sorin or a Ella or the company. So, but what happened to this is these boxes, let me tell you, were very old. Technology was made, they were all made for the older generation of devices and older Western world where there used to be analog telephone line, which now does not exist at all. So all the industry typically changed the device and put some kind of a cellular dongles or a cellular connectivity to that. So every company changed to different device, but the basic device remains same. The basic technology, the form factor may have changed, but the basic device remains same. Or the only thing probably you add is a little bit color and the cellular connectivity, but it is still the old technology. So this is how it looks like in the Western world. So whether you're programmer, whether your home device, they all send the data, the device data to Merlin.net or any company server, which physician can have access. But also the same data also goes to the hospital EHR and EMR, which is universal data, and that gets translated to that, and you have a technical support for that. Boston Latitude was the first remote monitoring where they tried to connect the device with an external device. So they use a blood pressure monitor and weighing scale, and these two devices used to send data, additional data to home monitor, and that used to also go to the server. So this was the first attempt when the remote monitoring took data other than from the implantable device, and this was used as for heart failure monitoring, as weight or blood pressure monitors and all. And then you can access this data, whether it is your referral physician or a cardiologist, you can access this data. And this is what I was referring. All these devices were pretty old. So analog line used to be basic connectivity option, and that is changing rapidly. So you can see one of the company data which says there are 350,000 patients which connected connectivity or which upgraded to different connectivity in a 1 year. So this is the remote monitoring we are familiar with. But now let's talk about another kind of a remote monitoring which is not very popular in India, but it is existing as acute care or emergency care in the Western world. So what is this? In Abbott or SGM, it is called as Merlin on Demand. In Medtronic, it's called as CareLink Express. That means basically your device, which will be kept at either the emergency room or in the surgery room or ER, will interrogate all the devices from that company, and it will send that data to hospital, to you, or maybe a technical support person, and it will send a fax data and all. And that company person or you can direct that what needs to be done. So the advantage is the person who is interrogating need not to know anything about the device. He is just putting a band there and interrogating this data. Same is the idea with the CareLink Express. So you have a box which is universal box, and data goes to some expert, device expert. He reviews it, and based on the review, he calls, fax, and send that data to this. So this is one scenario which is being tweaked in the Western world, in Europe and China and all these countries currently, and they are using it as one of the COVID way of managing device remotely, so that the doctor and the rep both are not available there at the clinic or ER and all. So that's the tweaked version of that. But what we are looking at in the remote care future is basically we are looking at clinical productivity. How we are trying to say the remote monitoring should be mobile, take it wherever it is, make it intraoperatable so that the data is connected to EMR, EHR, and the hospital network, and it goes as there, and get the programmer to info to server. So whatever even you are doing in a follow-up clinic or a device clinic, also feed that data to remote monitoring clinic so that the data remains there. And this is what is referred as big data. Everything is collated. And then the data all alone is not enough. Let's make some sense of this data. So what does data mean? So that is what is called part of the clinical predictability. And then seamless acquisition and distribution. Ideally, we don't need a home monitor. That is what we had a discussion in the panel, that these home monitor are a telephone-like device which remains at home. They are not portable. They are not mobile. So we need to get rid of these kind of things. Ideally, we would need that we could, or you as a doctor could also program device remotely. A person sitting at home and he needs some programming, you can do that. So that's the fancy or a wish we have. The virtual clinic and all those things, and remote assisted clinic. So that's another thing we just discussed. There has to be someone who looks at your data and reduce your burden, and the person can be as layman as it could be. So this is what we I think also discussed. There are aging people as well who are now using the smartphone, and all of them are using almost the smartphone on daily basis. This is the smartphone user population in India, which is now close to 40% or 36% currently. So that's smartphone, which is way higher than the US and all. So US, the penetration is actually lower than us, and that is what has indicated or asked people to go towards the mobile based solution. So these are the new devices which you are seeing or will be seeing soon, that these devices are Bluetooth enabled, whether they are from Medtronic or Abbott. So these devices are purely Bluetooth enabled, and that means the patient on mobile phone as the transmitter. So he need not to buy or keep a transmitter along with that, and it's going to be connected to Wi-Fi, cellular connectivity, and also you have your transmitter all the time working along. And when you have this advantage, technically what that means is your phone is in, at least in Abbott devices, your phone is talking to your mobile phone is talking to your ICD every 1 minute. Every 1 minute it is checking, do you have something to say? Do you have something to say? If you have something to say, I will transmit that. Or else patient will also have possibility to send the transmission, and you can review that transmission. So those are possibility what it brings, but those possibility are not happening or not becoming overnight. You need a technology which is going in the newer devices. So as I said, everything was changing in that box or a transmitter, and that those innovation were just add-on innovation one on another. Unless you change the device, the chipsets and all, you get into the newer generation, till the time you are not going to have. And that is what the newer devices will have now. The devices will have Bluetooth chipset. That means they have a seamless connectivity. And when you have that connectivity, the whole world is open. Now my ICD, as of now, it is talking to app, but you can imagine what may happen after 5 years or 10 years. It may be talking to Apple Watch or so on. The possibilities are endless. And when we have this, the compliance significantly increases, even in this one which we have as a new technology assessment. It's taking it to close to 97%, and all these are those aged patient, CRTD patient, and it is taking to 97% on their own phone. It is very challenging for industry to do so, because there are a lot of regulatory things and all which are coming in picture. So that's a big, bold move, but everybody is moving towards that. That's the good scenario. The another couple of solution which you will be seeing or hearing soon in the future is that can you do a remote programming, especially in these COVID days and all. Yes, so industry is working towards that. So you will be able to do a remote programming, and the remote programming will look like as we are doing a Zoom call. So your programmer is going to be shifted to your Zoom call or a Cisco or so on a secured server, and you will be able to see the programmer screen, and then you can suggest, annotate, change this parameter, change that parameter and all. So it is basically a local server, a local interrogation which is flowing over a Zoom call or a Cisco call. So these are the solutions you are going to have. And also, if you have these solutions, the companies may also come up with the solution like call center or a experts rep sitting somewhere and helping you in your follow-ups and all. And if the follow-up is probably normal, he need not to bother you. But if it is urgent, then he will probably flag it to you. So you will soon have these solutions coming in. But again, these solutions are nothing but extending programmer through like a Zoom call and all. What is the another thing, when we are integrating everything, one of the hurdle in remote monitoring is, I as an Abbott work differently, Medtronic work differently, somebody else work differently and all. So there has to be some solution which makes us together. So there are some solution available in the Western world, which takes up all the data from all remote monitoring and takes up the data from all the clinic, from all different hardware programmers, and collate it and send it to your EHR. And that means basically all your data from all companies will look exactly same, and it will work with your HL7 EHR hospital system. You can do billing, you can do storage, you can do whatever you want to do with that data. So it will be in a uniform database. So that's called as data integration. So there are solutions available for that. So this is one of the solution which is available. It takes data from implant, in clinic or remote, makes it together and send it to your EHR. So you need not to log into Merlin.net, CareLink and blah, blah, blah. And you will get data in your EHR in your way, in your language. And it takes data even from additional sources like Holter, ambulatory blood pressure monitoring, and also you will have combined data from all the devices flowing into your one system in EHR. And then you can do scheduling, you can do whatever you wish to do with that data. And it will simultaneously look all the device companies together. Now, the final part of this story is, if we have so much of a data, what do I do with that data? Right? So it should not be make a hurdle for me. The final piece of this remote monitoring, big data analytics is there are some solutions being developed where all the data on remote monitoring, you can pre-decided like a clinical trial. I need these parameters from my remote monitoring. Let's say I'm looking at a response of my CRT, how many patients are responding, how many patients are not responding. Am I looking at AF within my device patient? So it will automatically give you data that 20% of your device patient have AF, 20% of your CRT patient have AF, but 10% of your ICD patient have AF. So you will be running clinical trial within the clinic. How many of your ICD patient have a shock? How many of your patients who are primary prevention have a shock? So all the analytical data will come automatically to you. You will be able to also monitor the drug monitoring and the drug compliance monitoring. So those things are being worked out. And one piece which we discussed, I think during the panel discussion as well, one of the challenge for industry is cybersecurity. And cybersecurity does not concern as a manufacturer to us, but it is a scare to us because the regulator are too stringent on that. And there are multiple regulator, MHRA, US FDA, European Union, and so on and so forth. So there are too many of these. And that is where the Bluetooth devices which we are bringing, or which the entire industry is bringing, those devices are actually inherent cybersecurity enhancement. If you have an old device and you cannot upgrade that software of that device, that means that generation is gone, that cannot be updated. But if you have Bluetooth connectivity, if you have software which you can update daily, because it is a mobile app, you can send an update. Okay, I know that this is a cyber challenge. Let me send you another update. So you will be able to update the device, and you can also update that implantable devices. And these devices are made as per the global cybersecurity standard. And in fact, when we made it, we gave it to the hackers hackathon to hack whatever is the possible scenarios and we use the cybersecurity which are equal to your banking standards and all. So there is no malware which can corrupt these devices. The transfer between the device and the mobile device and the server happens cryptographically encrypted device. So you cannot decrypt that data at all. So it's harder than even hacking your banking system. Finally, what are the challenges? Why still it is not happening? As I discussed, regulatory hurdles are high for us. Every time there is something new, it's a challenge for us. But it is significantly not taken care, because now, as per the newer regulatory standard, your remote monitoring is class 2 and the implantable devices are class 3. So a lot of updates which can happen on a remote monitoring is possible now. Sometimes the remote monitoring is misunderstood by the patient, and sometimes even the cardiologist. They are scared that if there is a data, if I don't look at data, I will have a legal issues and all. So those things, and sometimes even the patient is having that notion that somebody is going to look at my data. If I have VT, I'm going to be monitored by my doctor and he will treat my VT. So it is misinterpreted or misprescribed to many patients as well. And then unfortunately, the commercial models and economic models does not exist much. So there are some companies who are bringing in the commercial models for these other than the device companies, which can make this whole thing work. And I think that will be the trigger point when whole thing will change. Technology grossly being taken care by mobile devices, but this will definitely increase the troubleshooting job of the industry. Healthcare involvement and knowledge. Many times physicians just want to implant and get rid of the device. Now that part, if that is the case, remote monitoring is not going to make sense to the cardiologist, because if you are not interested in that device parameter, if you have no knowledge about that device parameter, any amount of data is not going to make sense for you. So that's where the device knowledge is important. Interoperability, as we already discussed, if we continue to work in silos, different company, different data, it is going to cause a problem to you, because you can't get expertise in all manufacturer data. So that's where is the problem. And then there are another regulatory issue like US says my data has to be my data, Euro says my data has to be my data, and APAC, which is India and other things, they say data is free. It can be anywhere. And the first thing we find different in India other than the US is India people or India patient says, where is my data? I want to see my report. Though that report will not make any sense to that patient, but he still want to have a report because he feels it is negative or positive report. That's not going to be the case. And all these devices are made as per the US standard, which means the patient will not be able to access any data except for the basic data like battery and all those things. Rest of the data will not be accessible to patient because it is not making any sense to that. So this is my final slide, and that may not be too far, where we integrate all the data from your fitness devices, so on, your band and other things. And you will also have solutions by Google's iOS and all, where all the data, whether it is remote monitoring, whether it is device data, Apple Watch data, device data of respiratory, heart sound and all, will be combined, given to you as a solution or as a predictable solutions to you. All you need is you need to look at that sensitive data in future. So these are and sometime I envision future at least you may have a app on app store like Apple, which takes care of your all other data and integrate it for patient and sends it to you as a physician. So those things will develop. The platforms will develop, but as of now, it remains an isolation solutions. So thank you very much for your kind patience and hearing this long story. If there are any questions, I'm sure there would be. I'll be happy to take up some of those.
Thank you very much, Mohan, for nicely elucidating what is in store for us in future. However, one concern remains, because a lot of this technology has been around. Bluetooth has been around, cell phones, smartphones have been around, transmission wirelessly has been around. So our principal concern has been with the cyber security, particularly in the field of programming. Now, if you are able to program your devices in such a way that somebody, okay, it may be very difficult to hack it, but somebody will hack it someday, and then they can switch off your pacemaker, you can die. So what is the security against that?
Yeah, I agree. So that's why this remote programming, which is happening currently, or which is being developed currently, I think it's an fishy stage as of now, because whatever data you are giving, you are either giving through Cisco or a Zoom or whatever network you use. it's going to be difficult. And that is why, as of now, the companies are using the device will be mine device, so that it is in my network area. And that time the device cannot talk to any other device. So there is a secure tunnel built in for these transmission. But I agree that small part of it is still susceptible, at least.
Now, I suppose you may have to build in something whereby you cannot do a programming which will be endanger the life of the patient. So there may be some restrictions in the programming itself. So
Yeah,
that may at least prevent the life, save the life of the patient.
Right. So what happens, Dr. Mishra? The programming is not possible. What will happen is you will be seeing a programmer screen. On that programmer screen, you will be writing, annotating. Change
the patient mimics
rate
you
to 70. So you will write that change lower rate to 70. Person who is with the programmer, he will change it to 70.
Okay, basically the programming will have to be done physically, locally.
Exactly.
Not remotely.
Have is
Only
the remote
guidance.
access. You
Guidance.
have remote viewing of that.
Fair enough.
But Chander Mohan, if you are visualizing the programmer in Zoom in your desk, laptop, so and you are annotating, you are changing the cycle length and everything. So how is it possible that someone is there who is with the programmer and who is doing the same thing, and it is not concordant to what you spoke earlier. You gave an idea that it can be programmed remotely, remote programming. That's what you told.
Right.
So there is little bit of gray area, and a lot of
okay.
Concerns are there, definitely. And do we have any device like ILR which we are using now? Do they have this Bluetooth enabled? They have Bluetooth enabled devices.
Yes.
ILR.
Yes, sir. Yeah. So ILRs were the first one which were Bluetooth enabled, and ILR as of now were not programmable from far. It was only a monitoring. But now next generation of devices which Boston has launched, which Medtronic has launched, are remotely programmable. You can even program. And the other programming which I was talking, it will be like somebody sitting in your emergency room.
That is an extra,
the programmer. It will shift the data through a Zoom, and you will write on a Zoom.
So,
yeah, basically what I understand is what he's trying to say is you only get the programmer screen on your screen, and you physically, verbally direct the patient or somebody technician to program it according to what you want.
No, sir, that was that is like an additional feature, and he says he already said that it can be remotely programmable. You can on your screen program it. There are security issues are there, and I don't know. So, Thakur, are you saying that every time someone has to be there with programmer physically at at the patient's place so that can be programmed? So is that you mean with the remote programming, or you mean with the something outside remotely?
So what it will work like is, so your programmer which you have currently, let's say Boston Scientific and so on, Medtronic and all, that Boston Scientific data will go to a tab, which is again made by Boston Scientific. And that tab will start a session with you with a password entered by you, and then you will be in a session between that rep on the clinic and you sitting remotely. So you will be starting a secured tunnel, and then you will be seeing a remotely the screen of the programmer. And on that screen of the programmer, you will write, okay, change lower rate. So he will finally program that on a programmer.
Okay. Okay.
So that's the security as of now built in this.
Now that is a assisted programming.
Yes.
That is the assisted programming. That means one technical person is required. He may be a family member, he may be a patient, educated patient, but physical presence of one man is required to modify. That means the programmable parameters are there that can be directed from remote area, but that can be changed only by a person who is by the patient with a device.
That means that will be usually a company person.
Programming, assisted remote programming, not beyond that.
Right.
Is that the good thing is going in one side, and cybercrime is going in one side. That is
Right.
also getting advanced. So
Right.
I think it is time will say how far it is safe in future, because whatever we are thinking for time also. I think it will require some time, but otherwise this kind of remote monitoring, analysis of data will definitely help in our clinical advancement, because I can suppose I have implanted 500 pacemaker in last 5 years, and I can analyze my patients, how many patients are developing heart failure, how many patients are developing clinical heart failure, how many patients are developing atrial arrhythmias. I can detect.
Right.
That's a good advantage from research point of view, what you have pointed out.
Right.
But I think programmability will be a big issue in future.
I agree.
Should be educated, either patient or patient relative. This assisted part to be kept on. Just free access to program that device from a remote area will not be a good idea till now.
Yeah, agree. And that is why it'll be always by the paramedics or a company rep.
Yes. Other,
Well,
if you make it free, that you can change it from a remote area without any assistance, and the man is traveling in a train and someone is changing it, it will be
No. The FDA will not allow that much of a freedom, sir.
that freedom should not be allowed. I think it
Agree.
should be, for the time being now, it should be an assisted remote programming. I think that will be better. What is
Right.
Dilip and Dr. Mishra?
right. I think this is currently, that is the status, and we do not have enough security measures to allow a remote full programming. As you said, it has to be assisted. But I believe in due course of time, we are probably going to see fully remote programming, but not of all features, some of non-critical features, perhaps, so that you still have the safety of the patient with you. Now, how to go about it is this, people who are with cybercrime, they will be able to answer. But from what I have read till now, there have to be some secured channels, but also certain codes, certain things, what you know, what you are, and what you have. If you combine these three things together, there is 1 in a trillion chance that things will go wrong. So this will come in due course of time, I'm sure.
Dilip, any comment? I think we should hope for the best.
It was too overwhelming, and good to see, good to know, all these things, and these things are going to be reality. It's it looks gives us a very good insight. So I think wrapping up comments from you, sir, and then we can call it a day. Prakash da.
Any comment from Soumik? Unmute your.
Yes, sir. I'm listening to you, all of you, sir. I agree, sir. It's going to be a double-edged sword, sir. As we get more capabilities of programming, it's exactly the cyber issue is going to become stronger and stronger. If we want to cut out the cyber issue, we are going to lose the benefit of remote programming the patient. So there has to be I think Mr. Thakur has said the security issue is going to become a much bigger issue later. Because anything is hackable these days. Even with the best of security, hackers are going to get better. No doubt about that.
Narendra Modi's Twitter account has been hacked.
Yes.
Yesterday. So thank you, sir. I think we can call it a day. Thanks to all the moderators, Dr. Mishra, sir, Dr. P.C.Mondal. Soumik, great presentation. Thakur, as usual, you explained the things in lot of detail. And thanks to Team Abbott and everyone who attended. Thank you so much. And next week is the last, meeting of the entire series. And I hope you all will be there. Thank you, sir. Thank you, everyone.
Thank you, everyone. Thanks for
Thank you, sir.
opportunity.
Yeah, thanks.